My name is John Sievenpiper. I'm an associate professor in the Department of Nutritional Sciences, Faculty of Medicine, University of Toronto, and a staff physician in the Division of Endocrinology at St. Michael's Hospital. And it's my pleasure to present to you the big controversies: fat, sugar, and salt. What do I tell my patients? These are my disclosures. Well, fat, sugar, and salt really represent important controversies in nutrition. Patients and physicians alike have bombarded with mixed messages regarding these three nutrients of concern. What I propose to do is go through in the next 15 minutes or so each one of these in turn, asking important questions which inform the debate, and then following that up with data which provides some answers that we can struggle through together. If we look at the first controversy, fat, what are the headlines? Well, for the last 40 years, the message has been one of low-fat dietary advice. What's changed, or what's happening now, is a shift in the concern regarding fat. So if we look at these examples of headlines, what we see is butter is back. There's concerns regarding saturated fat are no longer what they once were, and there's a call to reevaluate saturated fat in the diet. What does the evidence say? Well, is saturated fat associated with cardiovascular disease? That's the first question. Well, if we look at existing and the totality of available prospective cohort studies, these are the best designed observational studies we have that give us a good assessment of the exposure to saturated fat, its confounders, which we can then adjust for, and ascertainment of the outcomes of that are patient important and public health important, from all-cause mortality through diabetes. What do we find? Well, this WHO Commission systematic review and meta-analysis, what it shows you is when you pool the totality of the evidence from those available cohorts, no association is seen with all-cause mortality, CHD mortality, cardiovascular mortality, CHD events, ischemic stroke, and type 2 diabetes. The question, though, is, does the replacement matter? And if we look at the same available cohort studies, what do we see? We don't consume in a vacuum. When we consume food, we tend to replace it or substitute it with something. So is it the case that anything is better than saturated fat, or is there a difference depending on what we substitute? So if we look at the available cohorts, and this represents a pooled analysis of the Harvard cohorts, what we see is the substitution does matter. If we substitute with trans fat, as was the case with margarines when saturated fat was replaced in margarine with trans fatty acids, there is no benefit, which is the top bar. But what we see is if we replace the saturated fat with monounsaturated fatty acids, in particular from plant sources, and polyunsaturated fatty acids or high-quality carbohydrate, as indicated here by whole grains or even low glycemic index carbohydrate, then there is advantages. There isn't an advantage if it's just a simple replacement with refined carbohydrate. That was the prospective cohorts. If we look at the randomized controlled trials, which give us a better protection against bias, that have looked at these same clinical outcomes, we see a similar story. So if we look at the WHO Commission systematic review and meta-analysis of the totality of randomized controlled trials in this area, what we see is the reduction of saturated fat in a trial setting does relate to a reduction in cardiovascular events, but that benefit appears to be restricted to the replacement of saturated fatty acids with polyunsaturated fatty acids, which I've indicated in red at the bottom. One does not see it when one substitutes carbohydrates or replaces the saturated fat with carbohydrates, protein, or in this case monounsaturated fatty acids, but that's relying only on one trial, so those data are uncertain. It really is restricted to polyunsaturated fatty acids. If we ask the question more specifically about specific types of polyunsaturated fatty acids, as has been done by Chris Ramsden at the NIH and his pooled analysis of the same trials, it appears it's actually those polyunsaturated fatty acids which are provided by mixed N3, N6 oils, which provide the benefit in relation here to cardiovascular mortality, a more important outcome. So increased granularity. Do the food sources matter? Is it that all sources of saturated fat are reliably associated with heart disease? The answer there is no. If we actually look at the available cohorts on this, we have this example from David Jacobs' group using the MESA cohort. What we see is that when we look at important food sources of saturated fat in the diet, those from dairy and plant sources, for example, are not reliably associated with coronary heart disease events. In fact, dairy is protective. All of the association appears to be restricted to saturated fatty acids from meat. So the food source may matter. Moving on to the next controversy, sugars. What are the headlines? Well, sugars have replaced fat as the dominant public health concern. Whereas we had 40 years of low-fat dietary advice with a focus on fat, the focus now is switched to sugars, and in particular fructose, which is thought to be the main bad actor among sugars and relate to a lot of cardiometabolic diseases. Most of the debate has been, initially was in the scientific literature, but the media lag has passed, and what we see is a very vigorous representation of this controversy in the lay media, and in particularly important sources of lay media, such as the New York Times, the most important financial paper in the world, the London Financial Times, important lay sources of scientific information, such as Scientific American and National Geographic, as well as the broadsheets in England, and a number of documentaries which I've shown there, Fed Up, for example, That Sugar Film, and Sugar Coated. Well, what does the evidence say? Are sugars associated with diabetes? That's the main question as it relates to cardiometabolic disease, which include obesity, diabetes, and cardiovascular disease. That's where the link is presumed to be the greatest. Well, we actually performed a series of systematic reviews and meta-analyses to look at the association of total sugars with diabetes. This represents the totality of available prospective cohort studies. This is the best designed, highest quality observational studies we have in more than 250,000 individuals. And what you can see from these summary estimates looking at total sugars, the exposure to total sugars, sucrose, and fructose, is there is no association seen with diabetes, much as was the case with saturated fat. And in fact, there is a protective association seen for sucrose. Now, I don't think that means that sucrose is necessarily protective and we should be consuming more sucrose, but I think it gives us confidence when the question is one of harm that there is no harm, there's no signal of harm from the available cohort studies. The question, though, one of the important questions in sugars, relating to sugars, is it the sugar or the calories? Is there something special about the sugars in that? Is there something unique about their metabolism and their endocrine responses that relate to cardiometabolic disease, or is it their calories? Well, here we can switch to the randomized controlled trial evidence where we get the best protection against bias, where we have two trial designs, feeding designs, which actually allow us to isolate the effect of sugars from that of energy. We have substitution trials where the sugars are simply swapped calorie for calorie in an energy matched under energy matched conditions with another macronutrient, in particular starch. So 1-for-1 swap, calories held equal. And we have addition trials. These are trials where the sugars, excess calories from sugars are added on top of the diet compared to the same diet without those excess calories from sugars. Well, what does the evidence say in this case? What do the substitution trials tell us in particular? Well, if we look across, and I've summarized here a series of systematic reviews and meta-analyses sponsored by the Canadian Institutes of Health Research that we've performed. If you look across a series of cardiometabolic endpoints from body weight through to fatty liver markers at the bottom of this slide, what you can see is there are no signals for harm across any of these. In fact, we actually see signals for benefit, a beneficial effect in terms of glycemic control and blood pressure. Again, we designed these analyses to ask the question of harm, so I think this gives us confidence there isn't harm. I would not suggest that this suggests that there's benefit. But what it speaks to directly is the question is anything better than sugars? Is that the case? And I think this shows you that no, that may not be the case. If we're replacing sugars with starch in this case, there appears to be no advantage, and there may be even instances where there are disadvantages. Well, what do the addition trials tell us? Well, if we look at the addition trials, this is where excess calories from sugars have been added on top of the diet compared to the same diet without those calories. Then we see everything that has come through in the headlines. We see an increase in weight, we see an increase in lipids, in postprandial lipids, in dysglycemia, in insulin resistance, an increase in uric acid, which relates to gout, and an increase in markers of fatty liver. In the absence of seeing an effect in the substitution trials, the interpretation then is that any of these adverse effects we're seeing here appear to be attributable to the excess calories rather than the sugar per se, which is to say it's not that there are some special set of metabolic or endocrine responses that relate to sugar that explain these adverse effects. It's the calories that appear to be driving it. But the question here, as was the question with saturated fat that needs to be asked, is do the food sources matter? And here we can go back to the observational evidence where we have some evidence of that. This represents a series of summary estimates from existing systematic reviews and meta-analyses that have looked at important food sources of sugars and their relationship with diabetes, going back to the diabetes question. And what you can see in this particular plot is that yes, sugar-sweetened beverages, which is really the elephant in the analysis, if you like, so sugar-sweetened beverages is a source of sugar, and fruit drinks and potentially fruit juices are associated with increased diabetes. I've put fruit juices in orange because there's greater uncertainty, but certainly sugar-sweetened beverages and fruit drinks do show an association with diabetes, and this is important as they represent the most important and dominant food source of sugars in the diet. But what about other important food sources from grain and grain-based products, from fruit and fruit products, dairy and dairy products, and from sweets and desserts? What do we see then? Well, surprisingly, I think we see no association of harm, and in fact, where I've indicated in green, we actually see a protective association, for example, of yogurt, even ice cream, which is, I think, quite surprising, and also from fruit and whole grain cereals. So it's not that all sources of sugars are reliably associated with diabetes. The signal appears to be specific to sugar-sweetened beverages. Sugar-sweetened beverages appear to be the special case. What about salt, our last controversy? Well, if we look at the headlines, the dominant message has been that sodium is a nutrient of concern, that sodium relates to cardiovascular disease and should be reduced. Now, sodium is an essential nutrient, and we certainly are aware that hyponatremia is a potentially dangerous medical condition. However, the message has really been that lower is better. Well, now the headlines have changed. The headlines are saying pour on the salt. New research suggests more is okay. Serious salt confusion. So now the headlines are beginning to shift, questioning whether that message actually is the right message. Well, what does the evidence say when we look at it? The first question we have to ask is, well, is sodium associated with cardiovascular disease? And when we ask that question, the approach to that question that's been taken by epidemiologists is one to link sodium to blood pressure, where we have a good established relationship from observational studies, and in particular from high-quality randomized control trials of sodium reduction, and that which I call A to B, and then link the relationship between blood pressure to cardiovascular disease, where again we have a very strong relationship from the epidemiology and from randomized control trials, in particular of ACE inhibitors and thiazide diuretics, linking a reduction in blood pressure to a reduction in cardiovascular disease. As such, this is taken as a causal pathway linking A to B to C, where the suggestion is that the relation of sodium then can be linked directly to that of cardiovascular disease. When one takes that approach in large pooling projects, and I give the example here of the NutriCode project that was published a couple of years ago in New England Journal of Medicine, a very large project involving 66 countries, what you can see is that using this relationship of sodium to blood pressure to cardiovascular disease, the authors project that sodium explains 10 to 20% of deaths from cardiovascular disease in those that are aged younger than 70, and about 5 to 10% in those aged greater than 70. The question is, though, I think that you should be asking, and one has to ask, is there a direct relationship if one relates sodium directly to cardiovascular disease? What then does one see? Well, when that question's been asked, then we have a number of systematic reviews and meta-analyses and large pooled analyses and large prospective cohorts which have looked at this question. One tends to see a U-shaped relationship, which I think is quite unexpected, but shouldn't be surprising given that this is an essential nutrient. And we know at low intakes, we tend to see of essential nutrients deficiency, adverse effects related to deficiency, and at high ends, we see adverse effects related to toxicology and toxicity. And that's the case we see here with sodium. At the low end, we see increased cardiovascular events, and at the high end, we see increased cardiovascular events. There's really a sweet spot, or a Goldilocks zone, if you like, in the middle, which represents actually quite a high intake of sodium, around 4,000 to 5,000 milligrams, which is just around the population average and much higher than the recommendation to consume less than 2,300 milligrams that we have today. This particular analysis was a pooled analysis done by Salim Yousaf's group. He's one of the biggest cardiovascular trialists in the world, led by Andrew Mente. It was out of McMaster, and it was a pooled analysis of their a combination of their epidemiological studies, their observational studies, and their randomized trials that they treated as cohorts. When they put all of these data together using spot urine sodium, which is considered a better marker than self-reported intake as it's an objective measure, what you can see here is this U-shaped relationship. But they went further to ask the question, is that relationship modified by the background health status of the individuals, which is to say hypertension. Given this relationship with blood pressure, is hypertension a modifying factor? And what they actually found was that in those that do not have hypertension, what you actually see is that U-shaped relationship changes such that at the low end there's still harm, but once you continue out along the curve, in terms of higher intake, you don't actually see higher events. It's only people that with hypertension that you actually see those events. There's modification by health status. The last question to ask here, and the same question we've had to ask for fats and sugars then, is, well, do the food sources and background diet matter? And I think we have a nice illustration of this from the DASH diet trials. In particular, one of my favorite trials, which is the DASH diet at 3 levels of sodium. The DASH diet represents a healthy blood pressure lowering diet. Its dietary approach is to stop hypertension. It emphasizes fruits and vegetables and whole grains, legumes, nuts, and seeds as a way to lower blood pressure, emphasizing nutrients such as potassium, magnesium, and calcium, which are associated with lower blood pressure, as a way to offset any effects of sodium. And what this trial showed compared to a control diet, which was a Western diet, is that the DASH diet at the highest level of sodium had the same blood pressure as a Western diet at the lowest level of sodium. So the levels of sodium here are about 3,500, 2,300, and 1,500. And what you can see is that the DASH diet at the highest level of sodium had the same blood pressure as the Western diet at the lowest level. Now, of course, the lower you go with blood pressure, even with the DASH diet, the lower the blood pressure. But the point here is that if you have a healthy background diet, emphasizing foods which we know may relate to lower blood pressure, you can offset any of the adverse effects of higher sodium and tolerate a higher sodium such that you can have a blood pressure that would be similar to that to a Western diet at the highest level of sodium. What are the implications of all this? What do I tell my patients? Well, I think you take the same approach that we've begun to take with the guidelines. We've had a major paradigm shift in guidelines and moving from nutrient-centric guidelines, which are about fat, sugar, and salt, to more food and dietary pattern-based recommendations. We initiated that change with the Canadian Diabetes Association. We're also initiating it with the Canadian Cardiovascular Society in Canada, and we're seeing the same change in guidelines around the world because people consume foods within dietary patterns, within lifestyle patterns, not nutrients in isolation. And just looking at nutrients alone prevents one from picking up very important interactions with other nutrients, with the foods in which they're consumed, the dietary patterns in which those foods are consumed, and the lifestyle patterns in which those dietary patterns are consumed. Well, what do the dietary pattern-based guidelines actually say and tell us? Well, if we look at the two Canadian examples, that from the Canadian Diabetes Association and Canadian Cardiovascular Society, first here the Canadian Diabetes Association, what you see is the recognition is that there is no one best diet for diabetes. There's a number of diets with with evidence of advantages and disadvantages, and the point is to fit those advantages and disadvantages with the values and preferences and treatment goals of your patient to find the diet that best fits with those. And you can see here a number of examples of dietary patterns, such as a Mediterranean dietary pattern, such as a DASH dietary pattern, as we discussed, low glycemic index dietary patterns, and so on. If one emphasizes these, the suggestion is then that fat, sugar, and salt will sort themselves out, and one can still anticipate the benefits in terms of reflected here as the advantages and disadvantages in this table. With the Canadian Cardiovascular Society, we've taken the same approach. There is no one best diet for cardiovascular disease. There's a number of diets with evidence of benefit, and those are listed here where we have evidence for various diets for cardiovascular disease prevention. And what we state here, and I think is implicit in all of these, and it's the point that I think I'm trying to make, which is that adherence is one of the most important determinants for attaining the benefits of any diet. And I've put that in red in the values and preferences section. So it's really incumbent on the physician to work with the advantages and disadvantages, work with the evidence of the advantages and disadvantages of different diets, and fit that again and align that with the values and preferences and treatment goals of the patient to get the best outcomes. So what are our conclusions? Well, fat, sugar, and salt, these big three controversies, will continue to be controversial. To address the limitations in the evidence, clinical practice guidelines, and public health policy, and I would suggest physicians are moving to, and dietitians are moving towards individualized nutrition with a shift away from one-size-fits-all nutrient-centric recommendations such as low-fat, low-carb, low-salt to dietary pattern-based recommendations. Physicians, with the assistance of a registered dietitian, where possible, should advise their patients on evidence-based dietary patterns which fit best with the values, preferences, prevention and treatment goals of the patient. If one does that, I think, the fat, sugar, and salt take care of themselves. One has to acknowledge in closing that it's possible to eat a healthy diet that's both low in fat, sugar, and salt and high, and it's really about finding the best diet with the best evidence that fits for your patient. With that, I thank you very much.